So this this week this week's lecture is the final uh, part of the heart failure with reduced ejection fraction lecture. So um, we uh, we have done three parts so far. Last week we did the clinical picture of heart failure with reduced ejection fraction. We discussed the history and physical, how important the history is, because you can make the diagnosis of heart failure with reduced ejection fraction by just history alone, and the physical examination can back it up. So we always say that once the heart is involved in any process, uh, once the heart is ailing, patient's going to present with shortness of breath. That's a given. So for heart failure with reduced ejection fraction, initially the patient will present with exertional dyspnea, shortness of breath with exertion. And then as the disease process progress, uh, as the disease process progress, then they'll develop shortness of breath at rest. Even before they do that, they'll present with orthopnea. That is, they have to prop themselves up in order to sleep. You can find out how many pillows they're using, or they may sleep sitting up in a chair. So orthopnea, and then PND, they go to bed, and then a few hours later they get up to sit up in bed to breathe. And we went through the pathophysiology of that. So PND is another feature of heart failure with reduced ejection fraction. Then we look at the signs and symptoms associated with heart failure with reduced ejection fraction. Of course, the lungs is going to be involved because the lungs is directly connected to the heart. So whenever the heart have any type of dysfunction, the lungs will be involved. So when you listen to the lungs, they will have rales or crackles. They will have increased heart rate, respiratory rate. So the respiratory rate will be increased. Don't be fooled sometime with the lungs might sound relatively clear where the patient have significant shortness of breath. So, don't be fooled with that. And then they will present with signs and symptoms related to poor cardiac output, such as fatigue, exercise intolerance, cool extremities, and confusion. Those are all related to the poor cardiac output. And again, when you examine the heart will examine large. They'll have a displaced apical beat. And so-called S3, the third heart sound, is it's almost pathognomonic of heart failure. So if you hear a S3, then again, that will support your diagnosis of heart failure. Mitral regurgitation, tricuspid regurgitation, so you can hear those murmurs. Those are holosystolic murmur, and you have to know how those murmur behave with respiration. So you can pinpoint and say, well, this is mitral regurgitation. Remember, mitral regurgitation, a left-sided murmur, it's a holosystolic murmur, so it's going to increase with expiration, whereas tricuspid regurgitation murmur is a right-sided murmur. It's also holosystolic, but it's going to increase with inspiration, and it's heard best along the left sternal border. If there's pulmonary hypertension, then the right side is gonna be compromised, and blood will back up into the venous system. So they will present with pedal edema of the lower extremities, ascites, If the patient is recumbent, lying in the bed for extended period of time, they'll have sacral edema, so and hepatomegaly. So don't remember tender hepatomegaly. So that when the liver will be tender and enlarged. So when you do your examination of the abdomen, the right lower quadrant, they will have tenderness there because the liver extend all the way down there, and the stretching of the hepatic, the liver capsule, elevated JVP, nocturia, all those type of things. We also discuss risk stratification. When when these patients come to you with heart failure with reduced ejection fraction, you want to risk stratify them. You want to tell them, what to expect, and in terms of prognosis. People like you who presents with class 2 heart failure, and you have X, Y, and Z, ejection fractions is whatever. You can tell them, well, your 1-year mortality is 20% or whatever. So you can risk stratify them, and we have discussed the Seattle heart failure model. That is it's not something you memorize. It's an app, and you put in the data, and it will give you it will risk stratify that patient for you. Then after that, we went into medical management. We started with the medicines that we use to treat heart failure with reduced ejection fraction. The medications that we looked at was beta blockers, and we said that there are a few beta blockers that will improve mortality and decrease heart failure admission. The ones that we use in the United States is metoprolol, succinate, and carvedilol. So those are the two beta blockers that we use in the United States that have been shown to improve mortality. There's a lot more beta blockers around. You have atenolol, you have propranolol, you have Bextra, which is bucindolol, and you have a lot of different beta blockers. But the ones that have been shown to improve survival or decrease mortality in patients with heart failure and reduced ejection fraction is metoprolol succinate, not metoprolol tartrate, metoprolol succinate and carvedilol. Bisoprolol was also shown to do that, but we don't use that in the United States, at least not much. This bisoprolol. Now we come to another group of medications that we use in heart failure with reduced ejection fraction is diuretics. Remember, when I put in bracket beside the medication a number and a letter, the number is the class, okay? So, the number is the class and the letter is the level of evidence. We went over that as well, where the class so the class can be either a medicine or a procedure, something that you need to do for the patient. And when we talk about class, we go from class 1 to class 2. Class 2 is divided into class 2A and class 2B, and then we have a class 3. Class 1 indication have to be done. If it's not done, or you don't use the medicine, or the procedure is not done, then that's grounds for medical malpractice. Okay, so when you see the number, it's a class. So diuretics in patients with heart failure with reduced ejection fraction have a class 1 indication and level of evidence C. So remember, the level of evidence goes from A, B, and C. So the level of evidence is not A. It's basically expert consensus. A group of guys who have been doing it for a long time come together and say, well, yeah, it should be done. But the class is a 1. And the diuretics that we use loop diuretics, and the reason why we call them loop diuretics because they act at the loop of Henle, and we have three of those. We have bumetanide, which goes as Bumex, furosemide, which goes as Lasix, and torsemide. Okay, and then we have other diuretics which act in the distal portion of the tubule, the thiazides, the metolazone, spironolactone, which is a potassium-sparing diuretics. So if the patient is fairly stable, you can use your oral diuretics. If the patient is an extremist, then you're going to have your intravenous diuretics. One of the things that I've found is that somehow physicians are a little bit scared when the patients are very sick, they're scared to use the diuretics. And I'll see patients, they're getting Lasix 40 milligram PO twice per day, but they're still fluid overloaded, so you have to treat the patient. You have to treat the patient. So what diuretics do? What's the role of diuretics in these patients? As you know, diuretics bring about the removal of fluid, so it improves symptoms. So diuretics improve symptoms and exercise tolerance. It sort of unload the heart, so to speak. So the patient will tell you that they're breathing better, and hence they can walk longer. But diuretics probably don't impact morbidity and mortality. At least that information is not known. But we don't think that diuretics improve mortality. Okay, it's mainly symptom relief. If you're using diuretics, the patient should have fluid retention. So there should be evidence of increased fluid on board. And you should also, when you're using diuretics, dietary sodium restriction. So, and you have to be strict. Patients should not be cooking with salt. They should not be adding salt to their meals. Stay away from tin and preserve substance. Daily weight. Remember, the most accurate means of assessing fluid overload is for weight. So your patient should know their dry weight, and they should weigh every day at the same time. Same clothing on, preferable nothing on. Just before they get out of they're going to get a bath in the morning or whatever. And so daily weight. And a rough guide, if they gain more than 3 pounds in a 24-hour period, then it's more than likely fluids. Okay, so this is a fairly busy chart, and it's a guide for our oral. So this is oral diuretics recommendation for use in patients with chronic heart failure. Chronic heart failure with reduced ejection fraction. So again, the loop diuretics, if you got the Bumex, okay, you can use 0.1 to 1 milligram once or twice per day. The maximum daily dose of the Bumex should be 10 milligrams. The duration of action is about 4 to 6 hours. For Lasix, okay, furosemide, okay, initial daily dose 10 to 20 once or twice per day, but you can go up to as much as 600. When I put patients on, say, 80 milligrams 3 times, or sometimes the pharmacists get a little bit on end, but I'm still well below the maximum total daily dose. If you have a patient who is very symptomatic, your job is to make sure that the patient, start breathing better. Because if the patient feel like they're drowning in their fluid, that's one of the worst feeling possible. So you have to be aggressive. You have to be aggressive, and then once a patient improves symptomatically, then you can reduce the dose. But starting dose 20 to 40, But if the patient is really sick, you can go up to 600 milligrams daily. Okay, the duration of action for furosemide Lasix is 6 to 8 hours, and then torsemide, we don't use it a lot, but initial dose 10 to 20. It's a once a day medication. You can go up to a maximum of 200, and it's a duration of action. Thiazide, they're give you some indication of the dose. I would not recommend the use of thiazide in these patients. I mean, you can, but be careful. These medicine can compromise renal function. However, if you have a patient who is on long-term furosemide or even Bumex, they can develop tolerance, and the medication may not be as effective as when it was started initially. So you might have to add either metolazone, okay, or spironolactone. Okay, that's okay. So and then we will talk about spironolactone and eplerenone, but not as a diuretic. Okay. All right. So the next class of medications is the ACE inhibitors, angiotensin converting enzyme inhibitors. So it has a class 1, and the level of evidence is A. So what this is telling you, that this have to be, if ACE inhibitors is not used in heart failure with reduced ejection fraction, it's medical malpractice. Okay, medical malpractice, because ACE inhibitors have been shown to reduce the risk of death and hospitalization in these patients. You should not use it, however, if the patient is pregnant, and you should always try to use the dose that was used in the clinical trials. We tend to use much lower dose than the dose that was used in the clinical trial, but try and see if you can get to those doses. Okay. Another busy slide, but these are some of the more common ACE inhibitors, and it gives you the initial dose and then the mean dose that was achieved in clinical trials. So the ones that we use, fairly common, enalapril. So enalapril, the starting dose is about 2.5 milligrams. So enalapril is a twice a day medicine. So some people give it once, but it's a twice a day medication. Start 2.5, but the maximum dose is about 10 to 20 milligram twice per day, and the dose that we use in clinical trial is about 16.6 milligrams per day. Okay, so another common one is lisinopril. Lisinopril is a once a day medication. We usually start 2.5 milligram once a day, and you can go up to about 20 to 40 milligrams. The dose that was used in clinical trials is about 32.5 to 35. We also use ramipril, so-called Altace, initial dose 1.25 to 2.5 once daily. You can go up to as much as 10 milligram once daily. So we used to use captopril. It's a short acting, it's a 3 times per day medication, so it fell out of favor. So enalapril, lisinopril, ramipril, and to a lesser extent quinapril. So ACE inhibitor have a class 1A indication, have to be used in patients with heart failure with reduced ejection fraction. It improves mortality and hospitalization for. Okay, so HARBs, angiotensin receptor blocker, also have a class 1A indication. So ACE inhibitors have a 1A indication, and HARBs, angiotensin receptor blocker, have a 1A indication. So you have to know those things. So so if it has a 1A indication if the patient is intolerant to an ACE inhibitor. So ACE inhibitors, some of the ACE inhibitors, commonly cause a cough or angioedema. So if the patient have angioedema, say to lisinopril, then you have to use a HARB, because now it has a 1A indication because the patient is intolerant to the ACE inhibitor. HARBs have been shown to reduce mortality and morbidity as well. So ACE inhibitors reduce more mortality and morbidity, also HARBs. Okay, but you're going to give a HARB if the patient is intolerant to ACE. So patient come to you with heart failure, reduced ejection fraction, newly diagnosed, you're going to give them an ACE inhibitor. However, if that patient took an ACE inhibitor for whatever reason before and is, have angioedema or had a cough or whatever, then the next medication in line is a HARB, angiotensin receptor blocker. It has a 1A indication. Remember, the number is the class and the letter is the level of evidence. HARBs have a 2A indication now. So the HARBs will get a 2A indication. If you say the patient was not intolerant to ACE inhibitor, didn't have a reaction to the ACE inhibitor, but you just want to use a HARB. You say you're comfortable in using Altase. So, it has a class that have a class 2 indication, 2A indication. Alternative to ACE inhibitors, first line therapy. Okay? And then a class 2B for using HARBs, you can use in addition of HARB in persistent symptomatic patient already taking ACE. I would strongly advise you guys not to do this. Okay, so even though it's there as a 2B, do not add a HARB and an ACE. Especially if the patient is taking aldosterone antagonist. So I would just remove the 2B from your lexicon, because you can get patients into trouble if you add the HARB to the ACE. They can develop significant hyperkalemia and you run into problems. All right. So HARBs have a class 3 indication. Remember what class 3 mean? Class 3 mean it's not indicated or it may cause harm. So HARBs have a class 3 indication. So you should not routinely combine an ACE inhibitor, a HARB, and an aldosterone antagonist, because the patient might develop profound hyperkalemia and die. And if this is in the United States, you're going to be sued. Okay, so you do not use this combination. Okay, ACE inhibitors, HARB, and an aldosterone antagonist. Okay. All right, so these are some of the common ARBs, angiotensin receptor blockers that are in use. Candesartan, okay, starting dose 4 to 8 milligrams, up to a maximum of 32 once per day. This is the dose that was used in clinical trial. Losartan, okay, 25 to 50 milligram once a day, starting dose up to about 50 to 150. This is the dose that was used in clinical trial. Then valsartan, 20 to 40 milligram twice per day. You want to get up to about 160 twice per day. This is a dose that was used in clinical trial. We're still not coming on to, we'll discuss the aldosterone antagonists separate. So let's not cloud the thing. Okay, now we come on to aldosterone receptor antagonists. So far we have seen a number of class 1A medications in heart failure with reduced ejection fraction, beta blockers. Okay, your metoprolol, succinate, carvedilol, ACE inhibitor of a class 1A. And then if the patient is intolerant to ACE, then HARBs have a 1A. Now, aldosterone receptor antagonist, it has a class 1, and it has a class 1 indication. Patients with heart failure with reduced ejection fraction. The ejection fraction, however, have to be less than or equal to 35%. So you have to pay close attention to these numbers. So for you to use an aldosterone receptor antagonist, the ejection fraction will be less than or equal to 35%. The patient have to be in New York Heart Association class 2 to 4 heart failure. Okay? The aldosterone receptor antagonists have been shown to reduce morbidity and mortality in these patients. However, if the creatinine is high, patient, you shouldn't use the medicine. So for male, you should make sure that the creatinine is less than 2.5 milligram percent. And for female, it should be less than 2 milligram percent. Okay, there's a creatinine. And the potassium should be less than 5 for you to start your aldosterone receptor antagonist. When you start your aldosterone receptor antagonist, the ones that are in common use is your spironolactone or your aldactone. And then there's a relatively new one we call eplerenone. That's relatively new. You're going to monitor the patient potassium and the renal function. It's very important that you monitor the serum potassium and the patient's renal function. Okay? You should also use aldosterone receptor antagonists in patients with heart failure if the ejection fraction is less than 40%, less than or equal to 40%. Okay, so remember, without a heart attack, it has to be ejection fraction to be less than or equal to 35%. But if they have a heart attack, then you can accept a little higher ejection fraction. So less than or equal to 40% for patients with acute myocardial infarction and heart failure. There are a number of trials that showed us that these aldosterone antagonists were beneficial. Okay, the so-called RALS trial, which means randomized aldosterone evaluation study, it showed that there was a 30% reduction in all-cause mortality with the aldosterone antagonists. It reduced the risk of sudden cardiac death in patients with ejection fraction less than or equal to 35%. So, and that is where this 35% came in, because if the patient had an ejection fraction less than or equal to 35%, the risk of sudden cardiac death was reduced. It also reduced heart failure hospitalization in these patients with ejection fraction less than or equal to 35%. So that is why we reserve these medications for patients with heart failure with ejection fraction less than or equal to 35%. Okay. The problem with in the RALS trial, we use aldactone or spironolactone. Okay, so we use aldactone, spironolactone in the RALS trial. It showed, a significant proportion of these patients had gynecomastia or breast pain. Okay, so 10% of patients had an enlarged breast or breast pain, and that was significant, especially for the male patients. They once they develop that, they don't want to do anything with that medication anymore. So eplerenone is a relatively new aldosterone antagonist, which is now on the market, and eplerenone also was shown to reduce all-cause deaths, reduce cardiovascular deaths, and reduce heart failure hospitalization. And the study that looked at eplerenone was the EMPhASIS heart failure study. So the EMPhASIS heart failure study, they use eplerenone in mild patients. Well, the acronym stands for eplerenone in mild patient hospitalization and survival study in heart failure. The eplerenone had a less than 1% gynecomastia or breast pain, so it is more tolerable for the male patients. So less than 1% gynecomastia or breast pain. You're going to start the eplerenone at a dose 25 to 50 milligram daily. If the patient have any type of renal compromise, kidney problems, or if the potassium is a little high, you want to start at the lower dose, 25 milligrams, but you can start at 50. When the patients are taking these medications, tell them to avoid food that is rich in potassium, banana, a lot of fruits, and also non-steroidal anti-inflammatory drugs, your Motrin and aspirin, stuff like that. For spironolactone or aldactone, the starting dose is 12.5 to 25 milligram daily. Okay, it's very important. So these are clinical stuff that you have to know, because you will hurt your patient if you don't follow these instructions. So the potassium level, once you start these medications, you have to get a potassium and a renal function study in 2 to 3 days, and again 7 days after you start the medicine. Okay, and then monthly for the first 3 months, and then every 3 months. Because if the renal function deteriorates, the potassium can go sky high, the patient can develop cardiac arrest. So you need to follow the potassium level closely, renal function. This basically just went over what I said there. So if the patient have normal renal function, for eplerenone, you can start your 25 or even 50. You're trying to maintain 50. For spironolactone, normal renal function, 12.5, 25, and the maintenance is about 25 once or twice daily. Again, remember, monitor the potassium and renal function. Very important. Okay, so now the busy slide saying basically the same thing. You have to monitor the renal function. After initiation, the first 3 days, then a week after, and then monthly. Okay. All right. So going on, continue with medical management. Hydralazine and isosorbide dinitrate have a class 1A indication. So the class is 1 and the level of evidence is A. Okay. So you should try and understand this combination, because it's important, especially if your patient is intolerant of ACE inhibitors or they can't tolerate ACE inhibitor ARBs. Then this combination have been shown to reduce morbidity and mortality, mainly in the African American population, but mainly in the African American population, but you can use it for all comers. So the hydralazine and isosorbide dinitrate. So hydralazine is a vasodilator, and the isosorbide dinitrate is a nitrate compound. Okay, so patients who are self-described as African American tend to benefit. When they did the study, patients who benefit were in New York Heart Association class 3 and 4. These patients were optimized with ACE inhibitors and beta blockers. So these patients were on guideline determined medical therapy optimized ACE inhibitors, beta blockers. And when they had hydralazine and isosorbide dinitrate, they still had reduced morbidity and mortality in these patients. So especially your African American patients who are on guideline determined medical therapy, if there's still room for improvement, you can add your hydralazine and isosorbide dinitrate. Okay, So again, that's a 1A indication. So if you're treating African American patients and they come to you, you can start this. You can start it straight up. It's a 1A indication. However, it get a class 2A, B. So class 2A is the class and B is the level of evidence. If the patient cannot take ACE inhibitors are hard, so Caucasian patient, whatever patient, if they cannot take ACE inhibitors or ARB, then you can give them the hydralazine isosorbide dinitrate, even though they're not African American. It's still benefit. You're going to start with hydralazine 37.5 milligrams 3 times per day. So if you're going to do it, you have to do what's recommended. I saw a patient today who was on hydralazine 10 milligrams twice per day. When you're treating the patient, you treat the patient. So the starting dose is 37.5 milligrams 3 times per day. And then with the isosorbide dinitrate, it's 20 milligrams 3 times per day. Okay, so these are the dose that, so these are the starting dose. The dose that was shown to bring about the reduction in mortality and improvement in hospitalization was hydralazine 75 milligrams 3 times per day, and the isosorbide dinitrate 40 milligrams 3 times per day. Again, if you're treating the patient, treat the patient. Don't just give them a little bit of a drug and hope for the best. So these are the dose that was shown to reduce mortality in clinical trials. So, if you look at guideline determined medical therapy, beta blockers, your ACE inhibitors, your ARBs, that hydralazine and nitrate is there. The relative risk reduction is significant with hydralazine and nitrates. The number needed to treat for mortality reduction, good with hydralazine. Relative risk reduction in heart failure, good with hydralazine. So hydralazine, so it's a combination of hydralazine and isosorbide dinitrate, which was shown to reduce morbidity and mortality in the African American population. Okay, medical management with digoxin. So digoxin comes in with a class 2A indication. So digoxin have a class 2A indication. So you can use it, or you may not want to use it. Digoxin do not have a class 1 indication. Digoxin, however, have been shown to decrease hospitalization for heart failure. It improves the symptoms of heart failure and quality of life, exercise tolerance, but no effect on mortality. However, if the digoxin level is high, there's an increase in mortality. So for that reason, a lot of people don't use it. You want to start your digoxin 0.125 milligram to 0.25 milligram daily. However, for older patients, you want to use a lower dose. If they have renal impairment, you want to lower the dose. Lean body mass, lower dose. And again, the plasma concentration should be 0.5 to 0.9. This is very important because if the plasma concentration of digoxin is higher than 0.9, there is increased mortality. So, for a drug that it has no effect on mortality if you do all the right stuff, but if the level goes up, you can kill the patient. Unless it's really indicated, I would not use it in a heart failure with reduced ejection fraction. Okay, what about anticoagulation? So anticoagulation, just pure anticoagulation in patients with heart failure with reduced ejection fraction is a class 3. So do not use anticoagulants, any of your anticoagulants, in patients with pure heart failure, regardless what the ejection fraction is. So it has a class 3 indications if the patient do not have atrial fibrillation. If the patient have atrial fibrillation, it's a different animal. Okay, so chronic heart failure, if the patient have if the patient have persistent atrial fibrillation, then it will get a class 1 indication if the patient have one risk factor. So the patient will have to have heart failure with reduced ejection fraction plus persistent atrial fibrillation and one risk factors. So remember, when we're talking about atrial fibrillation, we divide the risk factors into we divide the risk factors into congestive heart failure, hypertension, age, diabetes, and stroke. Okay. All right. So those are the risk factors that we're talking about. Okay. Congestive heart failure, age, hypertension, diabetes mellitus, and strokes. So class 1 indication if the patient have persistent atrial fibrillation, one risk factors. Class 2 if the patient have persistent atrial fibrillation without any risk factors. Class 3 if the patient have heart failure without atrial fibrillation. Do not do it. Okay? Statins have straight up class 3 indication. So the cholesterol medications, if all the patient have is heart failure with reduced ejection fraction and the cholesterol is okay, statins have a class 3, that it is not beneficial when it is solely prescribed for heart failure. However, if the patient have dyslipidemia, hypercholesterolemia, then it's a different scenario. The omega-3 fatty acids have a class 2A, reduced mortality and cardiovascular hospitalization. What about antiarrhythmic drugs? So we have a lot of patients who have heart failure with reduced ejection fraction, and you have to get an antiarrhythmic medication for them. They might have atrial fibrillation or whatever. Very important, most of the antiarrhythmic agents increase mortality in these patients. It will kill these patients, okay? The so-called CAST trial show that most of your antiarrhythmic is going to kill patients like this, okay? And the reason for that is because it has a negative inotropic effect. It further weakens the heart muscle, and it also have proarrhythmic. It will cause ventricular tachycardia, ventricular fibrillation. The only medications that were shown to be neutral and weren't killing these patients was amiodarone and dofetilide. Okay? Amiodarone and dofetilide. When in doubt, go with amiodarone. Okay? Dofetilide, the other name for dofetilide is Tickerson. The patient has to be hospitalized before he can start this medicine. So patients who have heart failure with reduced ejection fraction and you need something for the atrial fibrillation, amiodarone is the way to go. Calcium channel blockers should be avoided in patients with heart failure. So your cardizem and your verapamil should not be used in patients with heart failure with reduced ejection fraction. Amlodipine was shown to be okay. You can use it for hypertension. The others are what we call myocardial depressants. Okay. The reason because remember we talked about the CAST trial. The CAST trial is a landmark study. The CAST trial, I think, came out in 1993 or 1994. So the rationale for the CAST trial was PVCs, people who develop PVCs, we think that PVCs kill them. PVCs, premature ventricular beat, is a harbinger for ventricular tachycardia and sudden cardiac death, especially patients who had an acute myocardial infarction, a heart attack. So that was the thinking. PVCs is bad, so let's suppress PVCs. So they did a study, the so-called CAST trial, where they used 7 antiarrhythmic agents. And one group of patients, you know, get medication, and then another group didn't get any medication, and we followed them for a period of time. So a bunch of antiarrhythmics were used, and the only ones that that did not kill the patients were amiodarone and dofetilide. Sotalol killed them. Uh, Encanide killed a lot of them. All right, so Encanide is now off the market. So Encanide was, if you wanted to kill a patient, you could give them Encanide. Flecainide was okay if the ejection fraction is normal. So the CAST trial showed that if the ejection fraction is reduced, the only medications that were safe was amiodarone and dofetilide, the CAST trial. All right, so calcium channel blockers should not be used. Okay, the only one that you can use for hypertension is amlodipine. The PRAISE trial was the study that showed us that. Okay, non-steroidals. What about, patients that have heart failure with reduced ejection fraction? You're going to give them Motrin. Be careful because it inhibits the synthesis of renal prostaglandins, and as a result, you get vasodilatation in the kidneys. It's going to inhibit sodium reabsorption in the thick ascending loop of Henle and collecting duct. It's going to cause sodium and water retention, and it's going to blunt the effects of diuretics. So try to stay away from NSAIDs in these patients because it's going to further worsen the sodium and water retention and blunt the effects of diuretics. Okay, it's a very busy slide. Just basically just go over a lot of stuff that we went over. What about device therapy? So we're going to finish up with device therapy. So these patients, we can do so much for them, but if the function of the heart deteriorates to the point that it's not pumping, there's nothing much you can do for the heart. There are other things you can do, but the heart, the heart is just, the pump function is just not there. One of the things, patients who have heart failure with reduced ejection fraction, they tend to get arrhythmia. Okay, they're prone to get ventricular tachycardia and ventricular fibrillation, and we talk about sudden cardiac death. So sudden cardiac death kills a lot of these patients. Okay, arrhythmic death kills a lot of these patients. So even though the pump function is reduced, arrhythmias, ventricular tachycardia, ventricular fibrillation kill a lot of these patients, and we observed that. So we did studies using implantable cardioverter defibrillator therapy, and the primary function for implantable cardioverter defibrillator that's a class 1 indication. Remember, class 1 indication if you're going to prevent sudden cardiac death. Okay, but the ejection fraction have to be low. Okay, now if the patient had a heart attack, you have to wait 40 days after the heart attack, and if the ejection fraction is less than 35% and the patient is in a New York Heart Association class 2 to 3, then it's a class 1 indication for ICD. You should, if the patient have a heart attack, the next week, they should not be getting an ICD. You have to wait more than a month Because a lot of time the reason for waiting is initially the patient may have an ejection fraction of 30%. You wait a month or 6 weeks, and the ejection fraction is now 50%. So you have to wait. Post heart attacks, wait 40 days. That's the indication. Okay? And they also have to be in a New York Heart Association class 2 and 3. The ICD therapy have been shown to reduce mortality in patients with non-ischemic or ischemic heart disease. Okay? And it also will prevent primary prevention of sudden cardiac death. So the ejection fraction of less than 30% in these patients, but post heart attack less than 35%. The patient have to be on guideline determined medical therapy. The patient have to be on standard medical therapy. That is what this means. So if the patient is not on adequate medication, you shouldn't embark on an ICD therapy. Patient have to be on a beta blocker. They have to be on an ACE inhibitor. Have to be on aldosterone inhibitors, salt and salt restriction at least. Okay, and if you're going to put an ICD in, the patient should be able to survive more than 1 year. So if the patient have a cancer and is going to drop dead in 6 months, you shouldn't put an ICD in. That's not an indication. Okay. So for a heart attack, more than 40 days post MI, ejection fraction less than 35%. If they're in New York Heart Association class 2 to 3. However, if the patient is relatively asymptomatic, post heart attack 40 days, but if the ejection fraction is pretty low, less than 30%, you can also go ahead and put the ICD in. Remember, one of the major causes of death in these patients is sudden cardiac death from arrhythmias, so that is the reason for the ICD. Then we have CRT. This is cardiac resynchronized therapy, so-called BiV pacemaker. If you ever look at the echo on a patient who have heart failure, there is the contraction of the heart is not coordinated at all. And the reason for CRT, cardiac resynchronization therapy, is to coordinate the contraction. Because if you have a heart, or if you have any pump, and one area is pumping and the other area is moving away from, is not pumping, that pump is going to be ineffective. So the CRT tries to coordinate the contraction of the heart and ends to get a decent cardiac output. So CRT, these patients with heart failure with reduced ejection fraction, there is something we call dysynchrony. They tend to have dysynchrony. A lot of them have dysynchrony. Not all, but a lot of them have dysynchrony. So because of the areas of the heart is not contracting in a uniform manner, so to speak. But if you look at these patients with heart failure with reduced ejection fraction, if the ejection fraction is less than or equal to 35%, and they have a left bundle branch block, and the QRS duration is more than 150, it's almost certain that they're going to have dysynchrony, and CRT is indicated. So it gets a class 1 indication. Class 1 indication, that means it should be done in patients with heart failure with reduced ejection fraction, EF less than 35%, a left bundle branch block, and the QRS duration is more than 150 milliseconds. Okay. The patient should also have New York Heart Association class 2 to 4 and guideline determined medical therapy. So they should be on the standard medical therapy. standard medical therapy. So don't start giving device and doing all sort of these, all sort of stuff unless the patient's on adequate medical therapy. A class 2A indication for CRT, ejection fraction is equal to 35% if the patient have a non-left bundle branch block, but the QRS duration is more than 150, and they're in a New York Heart Association class 3 or 4 heart failure and guideline determined medical therapy. And so what we're saying is when you look at the QRS, if the QRS is very wide, the patient more than likely have dyssynchrony. The different areas of the heart are not coordinated in their contraction to effect a good cardiac output. So, you should definitely know the class 1 indication. Low ejection fraction, left bundle branch block, a wide QRS. New York Heart Association class 2 to 4 heart failure. Okay, have to be on adequate medical therapy. And then class 3 for CRT, if the QRS is narrow and the patient is not in New York Heart Association class 1 heart failure or 2, the patient is going to die within a short period of time. A lot of comorbidities or frailty limit good functional capacity. So another busy slide, but basically it says patient have to have a low ejection fraction. QRS have to be wide. Left bundle branch block, more than likely. All right, so we're going to finish up with stage D heart failure. So heart failure with reduced ejection fraction, stage D. So these are patients who are refractory. They have refractory heart failure. They're in the hospital every couple of weeks or once a month. So in those patients, water restriction may be beneficial. So not your common garden heart failure with reduced ejection fraction, you're going to restrict fluid. But the patient who is refractory, repeated admission, okay, very low ejection fraction. So if you're going to water restrict these patients, then it should be about 2 liters per day. But routine fluid restriction does not result in significant benefit. So your heart failure patient, don't just restrict their fluid. It's not beneficial. They have to have refractory heart failure. And if you're going to restrict the fluid, about 2 liters per day. Okay? But be careful about fluid restriction or water restriction, especially in hot or low humidity climates, because these patients can develop heat stroke. So do not, excessively restrict fluid in these patients. So especially in hot and humid climates. So inotropic support. So when we talk about inotropic support, remember the problem with these patients is the ejection fraction is low. The ability of the heart to pump is reduced. So we can give medications that increase the pumping function of the heart. That's what we call inotropic support. So patients, it has a class 1 indication. Okay, so if inotropic support, that is, you're given medicine to increase the contraction of the heart. If the patient is in cardiogenic shock, they should receive temporary intravenous inotropic support. So, patient blood pressure is low, cardiac output is low, you can start them on these medicines. It will maintain systemic perfusion and preserve end organ performance. So, a class 2A for inotropic, you can use the bridge. That is, if you're gonna say put an ICD in, or you're gonna put a BiV pacemaker in, you can use these medicine to bridge until you do those therapy. Um, um, but you have to remember the class 1 indication for inotropic support. So basically, patient cardiogenic shock, low blood pressure, low perfusion, you give it. We have a few patients who you can't do anything much for them. They're not candidate for heart transplant. They're not candidate for left ventricular assist device, and we give them long-term um, inotropic support. You can use short-term continuous intravenous inotropic support in patients with severe systolic dysfunction and low blood pressure. So a patient coming in and they're hypotensive and ejection fraction less than 20% and stuff, you can give it short-term. But sometimes we use it long-term as a palliative measure because these patients may not be amenable to anything else. So when the patient, if the patient have a stage D heart failure refractory and there's no contraindication to cardiac transplantation or mechanical circulatory support, then you can do these. Okay. Now, mechanical circulatory support is getting a lot of play because we don't have enough hearts. We don't have enough hearts for transplantation. So remember the problem is the heart is not pumping the blood, so the blood cannot get out of the heart. So if we can stick a device inside the heart and pump the blood out, then we solve the problem. So that's where we get these these mechanical circulatory support. So we have all different means of doing it. We stick something in the LV and pump the blood out. We can pump the blood out into the descending aorta. We can pump the blood out into the ascending aorta. We can, so basically you use an ancillary pump. So that's what that's what we call the mechanical circulatory support. There's not enough hearts. The best thing for someone who in stage D heart failure is for cardiac transplantation, but we don't have enough hearts. So we have patients who are surviving for long periods with mechanical circulatory supports, and we have different types. So inotropic support is fairly good. However, in the absence of specific indications or reason other than palliative care, you shouldn't do it. So it's a class 3 indication. And if the patient don't have low blood pressure, don't have impaired perfusion, and the cardiac output is not significantly depressed, then you shouldn't do it. That's a class 3 indication. Okay, but inotropic support is beneficial in some patients. It has to be stage D heart failure. So that concludes our heart failure with reduced ejection fraction lecture. Again,